ask all of the speakers to come up to the front. So we have about 15 minutes for questions, and there's 2 microphones on either side of the room. So feel free to come down and ask a question. Yes? Can you go to the microphone? Because I think this is being...
I think everybody can hear. POC.
It's being recorded, so that's why. Sorry. Yes.
Hello, Patrick. I'm with Vancouver Coastal Health. I usually test in the bathhouse and with Boys R Us outreach. POC testing, point of care testing for a quick antibody test. There is one available. I do believe that the Richmond company makes it. Other jurisdictions use it. Can we not get this in that small world of testing? There are a significant number of people who just come in for the HIV POC testing. We could also have the antibody test. If they're positive, we can, encourage them to get the blood test immediately and follow up from there. So there's about perhaps a quarter to a fifth, maybe, who come in just in the bathhouse just for anonymous, non-nominal, or nominal POC HIV testing. So in there's a small group of people in small venues that could really benefit from this. Can we move on this?
I think, Troy, probably you're best to speak to that.
So I can speak to this. So that's a great point, and I think POC testing for syphilis would probably, in the context of a good performing test, would be critical. Would be a critical tool. So one of the limitations with this is all of this testing needs to be validated in some way. So Mohammed Morshed, who's the head of the syphilis lab at the CDC, I don't know exactly which ones he tested, but he did test a number of different POC tests to see how they performed and to see whether you could validate them for use in specifically in the context. We spoke specifically about the context in the bathhouse, and they didn't perform well enough, especially in the early stages, to be of any use. And again, the validation part takes some money, so there are limited funds to do this in the lab. But if I could find out from him which tests he actually used, I don't know. There are different tests available out there. Some of them are made sort of offshore and are used in other parts of the world. I didn't realize, and I don't know if he realizes, that there's a more local test, and I don't know how it performs. But if we could, I'll touch base with him, and if you could maybe send me the name of the company, or just so I could. Pardon me? Insti? Oh, it's the Insti. Okay.
They do a syphilis test? I didn't know they did. Oh, wow.
Is it a combo test? Is it that combo test? Okay, so that was actually looked at a few years ago before my arrival here. I think Rich Lester he had some in his office because I found them when I moved in. But
That's helpful.
So yeah, I mean, I'll see whether or not they were ever looked at in a more systematic, validated way.
Jody.
Jody Jollenwer. Apologize, I was in a couple of other sessions, so this may have come up in your presentations, but some community members were surprised to find out this year when we ran out of shots, not vaccinations, but treatment shots, that you could actually take doxy for 2 weeks to treat your syphilis infection. And community members were surprised that they had been put through the pain of these shots. And I'm asking on behalf of the community, why is it that we don't use doxy more regularly to treat? And do we have any data on whether or not, like you're talking about repeat infections, right? Do we have any data on how many guys just don't go back because they don't want that shot again, or those 2 shots?
Yeah.
Oh, no, I said to
I
you.
thought you said.
Yeah.
Yeah. So, in STI treatment guidelines and that sort of thing, things are always sort of put into different orders. So there's, preferred treatment and alternative treatment. Certainly for penicillin based on for syphilis based on the evidence, Bicillin is the preferred treatment. Though, when you look at the data, it has a slight advantage. So that's the main reason in terms of efficacy. For efficacy, there's a slight advantage, but they're pretty equivalent for early infection. but there is a slight advantage for Bicillin. The other key thing with Bicillin is that we know that doxycycline is very well tolerated, but a 2-week course of antibiotics, people are going to miss doses, and by getting a shot at one time, it's you're ensuring adherence, and we know that.
Sure. I
I mean,
totally get it.
for that particular, you're ensuring that the treatment is completed, right? Because it's in many cases for early syphilis, it's a one shot deal. Well, 2 shots, but 1 visit. So, when STI treatment guidelines are sort of put together, they always take those things, not just efficacy, but other things into consideration. So that's the main reason why. And then certainly for other forms of syphilis, so things like, neurosyphilis and, oral doxycycline would never be even considered. And in some cases, doxycycline can't be used. So that's why. It's really how effective it is, and also in terms of the ease with which it can be given and ensure that treatment is completed, because treatment completion is essential in determining the success. The other question was.
Would you also, I think one of the other pieces that I would add to that is that one of the things we find is that when people are having persistently high titers and we're trying to figure out what sort of, how to stage a diagnosis, what sort of treatment is best, it's often complicated if people have had previously a syphilis infection and have used doxycycline, because it's really hard to know whether or not that was a treatment failure in that case, or if the person just wasn't able to stick with the really strict 1 pill twice a day for 14 to 28 days regimen. And so it ends up sometimes having implications for their future care and their future health. I think that's something that we...
Yeah, and the other thing I just thought of as well that I'll throw out there is Bicillin works much more quickly. If you're thinking about, the whole treating acute syphilis and preventing sort of onward transmission a bit more quickly, Bicillin just works more quickly because it's, you count treatment completion date as the time from the shot. So that's the other thing. The other question you had was whether we've looked at people not returning. I think maybe Lauren might be able to speak to that anecdotally. We haven't looked at it in a sort of formal way, as far as I know.
Well, I think what I would say to that is when people have had really negative experiences with Bicillin, we would never force anyone to be treated with Bicillin. There's always accommodations that are made to meet the needs of each individual. So I can't imagine anyone ever being like, any healthcare provider insisting that a person should take Bicillin if there's any reason for that person to feel strongly otherwise. We definitely have those conversations with people and make sure they understand the benefits and risks of each treatment plan.
I'd just like to advocate for choice on behalf of gay men, and I think we know that some gay men avoid HIV testing because of needles, and that is a very small needle compared to some of the ones that you're treating, right? So
Yeah.
I just think if more of us knew that there were an option, we might be a little more engaged in the syphilis fight, because we might feel like we don't, like the only option is sort of, like I've heard of people passing out, and anyway. Thanks. That's my rant about the shot.
It's not a neutral experience. It's not. It's a really good point.
Great.
Yeah, I wanted to add as well. I think I'm really glad you brought that up, because I think when we're thinking about the drivers and certainly the reinfection piece, there's people who get infected over and over, and potentially one of those reasons is that they're not interested in the shot. There might be some deterrent there. So I think understanding whether that's the case is really important. So thank you for bringing that up.
Great. Jeff.
Hi, Jeff Ford, fleeing the U.S. from Emory University. All great presentations, thank you. I have a question for you, Troy, around the syphilis pre-exposure prophylaxis, a really interesting idea and study. I'm wondering if there's any concerns around kind of in between the testing period. So there's some difficulties with adherence. Someone stops their doxy for a couple weeks, contracts syphilis, and then treats themselves because they've restarted their doxy. Are there any, have you looked at that, or any concerns around how you're going to monitor the titers with that? So they may have, had a 1 to 64 2 weeks ago, but by the time you've drawn their labs, it's been treated. I'm just wondering if there are any concerns or how you work through that, because Lauren did mention some issues around how we deal with that when it's used as second line therapy.
Yeah, that's a really good point, actually. So, well, the idea behind the study, which is like clearly unproven, is that taking doxycycline one pill once daily, so 100 milligrams daily, would be sufficient to prevent infection. But again, it is unproven. The best that we can do with that is what we already do and how we already try to determine. And again, it's, as Lauren pointed out, it can be pretty complicated sometimes to determine, oh, is this a new infection? Is this just kind of lab variation? So we would just, within the context of the study, we'd be following the titers anytime they get blood work done. So that's how we would try to determine. And if we're doing titers every 3 months, certainly we should catch a new infection, because you should see a significant rise in the titer, which would indicate a new infection. So a breakthrough infection or whatever. So that would be the way to try to determine that. So there wouldn't be, in terms of a lag in diagnosis, there shouldn't be a lag of more than about 3 months in the context of the study, because we would be doing blood work that often. So.
Gotcha. Thanks. And then just a quick last question. Assuming this works and it's fabulous, did you have any initial thoughts around how this might be rolled out in the Vancouver context of infection?
Yeah, I think the key thing that I've sort of added to my rethinking of this study since the initial submission was really focusing on it as a focused, time-limited intervention. So I think we would need to take the data from the study and really figure out who, because it's not going to be for everyone. Just like HIV prep isn't necessarily appropriate for everyone. There would need to be sort of criteria to follow to really, and I think, in my opinion, you would almost need to be a bit more cautious with this, just because there's a lot of unknowns with antimicrobial resistance and that sort of thing. So there would really need to be criteria, evidence-based criteria on who to use it, who could use it. Also, really keeping in mind that this is meant to be a time-limited intervention for the period of risk, because we know people's risk changes over time. Relationships change and that sort of thing. So. I don't know. We would have to really think about how to do that. I mean, there was some interest in just doing this offering this to some people who were sort of had repeat infections, just in the context of kind of a public health intervention. And we initially thought that might be a good idea, but I kind of have been advocating against that because we just don't know enough.
Great.
Good morning. Thank you for being here. I'm Tom McAuliffe, Vice Chair of Positive Living BC. First, I want to make a comment on the injection shots of syphilis before I ask my questions. Full disclosure, I appeared up on the slide somewhere in the graph that described people with multiple diagnoses, and I don't know if I've had 4 or 5 or 6 infections. I know I've had many. Most of them have occurred since 2000, when I was using crystal meth and partying a lot, and re-exposure was due to sexual activity, not to getting tested and getting treated. Because I was HIV since '85, I'd been getting syphilis tests once a year up till 2000, and then more recently, because of my history, every 3 months. The story I want to tell about the injection site is I've had many experiences with treatment of syphilis, and in one of these cases I was traveling for the community back to Ontario for conferences and so on, and I had to split my treatments between Vancouver, Ottawa, and Toronto. And in Ottawa, when I went to the clinic there, after about 3 hours of going through the process of getting registered and all of that, they came to treat me. And when they went, and I say they because 2 individuals came and they shot both cheeks at the same time. And let me tell you, that was the best experience ever, because your brain doesn't know which cheek to freak out about. And by the time it's figured out, it doesn't know which one's more sore. It's all over. So that was actually a good experience. Please, it was brilliant, because it really did. It was way less painful that way. So first, I'd like to ask of Olivier, in your study with the stigma issues at the front of your graphs, it seemed to me that the study captured the adult issues of discrimination and stigma. I'm curious if there's any work been done to look at childhood trauma and how that relates to the risky behaviors of HIV infection and risk behaviors for sexual activity. For myself, I didn't experience a lot of discrimination as an adult, but I was sexually abused as a child, and that has the implications of PTSD kind of stuff. So I'm curious if your study looked beyond adulthood as cause.
Yeah, the study looked at both the experience of anti-gay stigma within the last year and lifetime experience. So we don't precisely know when that experience happened, but we know from other study that most of the time when people report a lifetime experience, it happened in youth. So we did find this, but in this context of this research, we did not look at child sexual abuse in relationship to syphilis infection, and there's a lot of Sex Now surveys, so I get confused with all the survey, and I'm not sure if we asked about sexual abuse in the last edition of Sex Now survey, but if we did, I did not look yet at if it has a link with syphilis infection, and we might be able to look at it, and it's a very good suggestion because there's actually a lot of research that has shown that in the syndemic literature, but also the greater literature, the relationship between childhood trauma and sexual abuse in childhood and HIV risk, but I don't know if it's been done yet in the context of syphilis, and maybe some other people know.
Yeah, I'm not familiar with that either, but I think we might have looked at mental health. So some of that PTSD, some of those pieces might have come out, but I think it's definitely worth looking at more closely.
Great. Secondly, I'm also one of the rare cases recorded where HIV infection stimulated a false positive test for syphilis. We know it was false positive because I had to go through 10 days of 24 hours pumped IV penicillin into my system. I had to sleep with the pump. It was very interesting. In the end, none of my 7 sexual contacts had contracted syphilis, and I've had like 12, 13 LPs in my life. That also showed that it didn't cross the brain stem barrier. We don't really hear a lot about this anymore, but I'm curious if there are still instances of HIV stimulated false testing of syphilis. Thank you.
Sure. Yeah, so there's a number of different reasons why people can get false positive syphilis tests. There's a long list of them. I think the testing that we have now, so the testing algorithm in BC was changed in 2014. Prior to that, we would always start with the RPR, which is the number that gives you, the test that gives you the titer, so 1 in whatever. And now we have what we feel is a better test in terms of finding more cases of maybe remote syphilis. So people who were maybe infected several years ago and now their RPR, their titer is maybe non-reactive, which can happen even in untreated syphilis. So that initial test we do now is a little bit more sensitive, but it's also prone to being, because it's so sensitive, it's prone to being falsely positive. And there are ways we can do that because we do a number of other different tests within syphilis. We can often figure out if something looks false positive.
Right.
Yeah.
I'm one of the curious results of that false positive is my titer number has never come below 1/16. And often has been 1/32, depending on the lab that's tested me. This is where I've gotten so many LPs because I've been my doctor was contacted by the head of the disease control to tell me to go get another LP. They all proved what they did, and it was obvious my numbers. When I did have an infection, my numbers were 1/1028 or whatever that number is. So with this new testing, is this possibly why I haven't been contacted in 2 years now? Even though that number, my 1/16, hasn't reduced.
So no. So this is a whole other. This is actually a whole a slightly different issue. I'll just backtrack and say we're always very worried about syphilis in people and making sure that people are treated appropriately. And we want to see the titers come down. And our magic number really is 1 in 8. So after treatment, we want people to eventually, usually within 2 years, get below 1 in 8. And if people don't get below 1 in 8, we start worrying and we start asking questions. So. Is this nothing? So in many cases, it's what we call serofast. It probably has no clinical relevance. It probably has it doesn't predict anything bad happening. But there are other possibilities for why the titer might not drop below 1 in 8. And that can be infection that's hiding somewhere. So one of the key areas we worry about is the central nervous system. So is there syphilis kind of hanging out in an area where the routine treatment wouldn't necessarily get there? And that's why the titer's persistently elevated, because there's some organism being pumped out of this area. So that's why we always worry, and we always try to get people to do lumbar punctures. After a certain amount of time where we see a pattern, some people just land at a certain number and they don't budge. So after, in many cases, after people have been worked up a fair bit, maybe they've had multiple lumbar punctures, case in point, and we just see the same pattern. Sometimes we'll just say, okay, well, this is kind of your standard, your normal, and we usually won't necessarily pursue it anymore. But we just worry a lot when we see these titers that are high.
I'm glad you do, by the way.
Pardon me?
I'm glad you do worry about that.
Yeah, maybe we worry too much.
And I can see that we're pressed for time,
Yes.
but if any clinicians or anyone wants to talk, as someone who's administered a lot of bicillin, if anyone would like to talk about things that can make the experience for patients less painful, I'd be happy to talk about that, because I think different clinicians administer the medication really differently, so we can talk about some things that make it less painful if you want to talk afterwards.
We do the double cheek thing at the CDC. So.
Is that the truth?
Yeah,
Yeah.
You get 2 clinicians to come in and treat?
usually, yeah.
All right, I'll also pass that on.
Are you tweeting about it? Let's see what you're from.
Can I ask, is this a quick question? Because we're over time. Great.
Okay. It's coming from Olivier's presentation about just how dramatic the difference between syphilis rates in gay and bi men were. Wondering whether that was consistent regionally, or if the different migration patterns might have played a role in that, and what your suspicions were as to why it was so big.
Yeah, well, I think we see this trend across province and across geographical region, and obviously there are, and also I have to say that obviously syphilis seems to be affecting more like urban men as well, but the perhaps I didn't do a very good job at presenting it, but one of the main reason why the majority why it reside in the slide just after is that the majority of bisexual men are actually partnered with a woman. And we are seeing from previous iteration of the survey that men that are partnered with a woman are less likely they have less sexual partner, and they also engage in less kind of risky sexual behaviors. So I think this is, I look at it differently in the slide, but I think we need to take into consideration that the vast majority of bisexual men are actually partnered with a woman, and when we look at the bisexual men who are single or partnered with a man, they tend to kind of have the same rate as gay men.
Mm-hmm. Great. Well, thank you, panelists. That was a great presentation. All right. So I think we start up again at 11. Yeah.